Many of our patients come to the hospital on medications that help reduce the risk of heart attack. Beta blocker is a good example. It's a medication that slows down the heart, decreases the amount of oxygen the heart has to consume, and by doing so makes it so a patient with heart disease can avoid having a heart attack. After surgery, it's critically important that they are restarted on these beta blockers because after surgery the heart rate increases because of pain and stress, and as the heart rate increases, the heart itself demands more oxygen. In a patient who has cardiac disease, this can result in a heart attack if the heart is not appropriately blocked. The scope metrics you'll see in your report include the percentage of the time that a beta blocker is continued after surgery. Making that 100% is what our goal is. If you're finding that at your hospital you're less than 100%, it requires an intervention. The actions that you might try when you find that you're underperforming on this metric include calling together a team of pharmacologists and surgeons, even anesthesiologists, to look at why cases may have missed a beta blocker restart after surgery. This root cause analysis usually helps to identify what the problem is. Sometimes it's that there was no protocol to put the patient on an intravenous beta blocker when they came in on an oral beta blocker. Sometimes it's simply that there's a lack of awareness about the importance of the beta blockade after surgery. That's why it's on the Scope Surgical Checklist. When talking to surgeons about this important metric, it's important that they understand that beta blocker withdrawal increases the risk of a heart attack by 3- or 4-fold. This is a tremendous opportunity to avoid heart attacks after surgery. They should also understand their role in preventing beta blocker withdrawal. The Scope Surgical Checklist clearly lays out whether or not a patient's on a beta blocker and what the plan for postoperative beta blockers is. Lastly, you may find some skepticism among surgeons because a prior beta blocker metric that was circulated nationwide related to whether or not a patient was on a beta blocker before an operation and was giving recommendations about who should start beta blockers. This is not that metric. This metric simply refers to a patient who comes in the hospital on a beta blocker and whether or not it was continued after surgery. Now, when talking with administrators, it's important that they also understand that avoiding heart attacks after surgery is a great way to deliver more efficient care. They should also know that this is becoming a pay-for-performance metric. So in both ways, quality and efficiency, this is a metric worth chasing.